So basically, yeah, as Angus suggested, this is a session for us to discuss when maybe particularly earlier in our time in the service, things maybe didn't go the way that they would want them to, that we would want them to. I thought this was a really useful example for us to discuss here, because actually we had two jobs in the same night with the same sort of pre-hospital crew, both from an aeromedical and a sort of a general ambulance perspective, and so there was useful opportunities to learn a little bit about the human factors. One way how not to really do it, and another way maybe hopefully to do it a little bit better. So there's two cases. So the first case, maybe we'll skip on to the next slide if you can, Angus.
Yeah, you're there.
Can you hear me?
Yep. Should be able to see it.
All right, we're on slide 2. It's not coming up on mine. So it's, just to set a bit of a scene, so it's 10 p.m. at night. I'm on the Aero 95 car with Jackie, and we get tasked to a guy who's 40 years old. He's cut his wrists and he's taken basically every tablet he owns in a sort of self-harm attempt. And basically the first crew have got to him with about 2.5 litres of blood loss in a bath, peri-arrest, and with sort of empty packets of medications all around him. And he's on the 3rd floor of a housing block somewhere in the eastern suburbs, one of those sort of 3-story situations with no lift, in a bit of a spot. And so they've extricated the patient. They've got him down the stairs in a Stokes basket, down 3 flights of stairs to the ground floor. And we've basically met the team in the vestibule at the bottom of these stairs. That's well lit, but it's really cramped. It's about 50 meters from the road with all of our vehicles. And there's pretty minimal access to the patient, about 90 degrees of sort of access at the most, really no working space at all. And we sort of arrived in this vestibule area. They're all quite sweaty. They've been working their ass off, obviously. And the initial handover sort of started and stuttered, and there was at one point in the handover the words, "We're not sure if we have a pulse," at which point we had to interrupt the handover and say, "Okay, can we check for a pulse?" So it felt a little bit chaotic to start. Broadly, this guy, as they had him, had an eye gel in that was working well. He had unrecordable SATs, probably because of the trace. He had a central thready pulse, a heart rate of 160, no recordable blood pressure, and he was pale and sweaty. And in and amongst that, he'd lost the cannula in extrication that they'd managed to expertly place, with a flat GCS tolerating the eye gel. So he was sick. Our initial steps were to move him out to sort of a courtyard area, to try and just get him out of this really tight space. It had great access, but was really poorly lit, and sort of without really much discussion, the team kind of stopped in this area because I think there was a general feeling that we'd fixed our space problem, but we then were bedded down in this poorly lit area, and everyone started to get to work and couldn't really see what we were doing. And as a result, it really became quite chaotic very quickly. My perspective at this point was there was not really much of a cohesive plan. I wasn't really sure exactly who was leading this situation. It certainly at the time didn't seem to be me. And the patient was critically ill and peri-arrest. So, and the inspector at the job also kind of identified this, I guess, lack of team leadership and cohesive team direction. So said, look, can someone volunteer to be a team leader? And nobody really put their hands up. So I eventually did, because I was quite concerned that it was all getting out of control and it was all getting away from us. So we regrouped and outlined the priorities to the team, which from my perspective was the guy was in hemorrhagic shock. He needed blood. We had no IV access, so we had to fix that first. He's obtunded and eventually he'll need an RSI, but at the moment he needs blood first. And then that the overdose was, a side issue. It wasn't really the major factor for us just yet. So we put a couple of IOs in, gave him some blood, eventually got him stable enough to an RSI, and then got him to an MTC with blood hanging on our arrival. And ultimately, the patient actually ended up having a really good outcome, and was discharged from ICU about 3 days later to a psychiatric ward. And so we then kind of, we went our separate ways a little bit, and then we might move on to the next slide now, Angus. And then at 2 a.m, same night shift, myself and Jackie again on Aero 95. get tasked to another address in the eastern suburbs, where we met the same ICP and three new P1 paramedics, and this time to a 15-year-old female who was suffering from an out-of-hospital cardiac arrest. Now, at the time where we'd been called 27 minutes after the initial event. We got to the patient 50 minutes after the initial witnessed arrest, and in that time, the pre-hospital team had completed a really complex extrication from the back of a house, where essentially the mother was a hoarder, and this 15-year-old child was in the bathroom in the back of the house where she had arrested. So the corridors were completely obstructed with all this sort of crap, basically. They tasked some police officers to basically just get a shovel and throw it all on the front porch, and it was so congested that they couldn't even do that. So they had to lift the stretcher out at above head height and sort of sidestep down this obstructed corridor to even get this kid out, and pausing CPR, accepting that there was nothing they could do but that. All the while, there's quite a distressed and quite obstructive parent who's becoming violent towards the team, and the police had to get involved with that. So it was a pretty complicated scene, and they've been working their ass off. And so we basically met them pretty much as you see with this image here. It was kind of like that. We just sort of met them at the side door of the back of the car, where they're busy working, running good quality ALS with an ETT in situ, and the patient remains in PEA at 50 minutes post arrest. And this time around, we sort of gave a nod, and there was obvious familiarity from about 2-3 hours prior. And I remember saying to the ICP, you know, how can we help, rather than sort of just bowling in and starting doing stuff. And I think that helped us integrate into the team rather than doing anything like assuming a team leadership, which was really not necessary. They were doing an excellent job. And that meant that they could direct us to the areas that they hadn't got to yet and just needed extra hands on. So we managed to do an echo. We treated some presumed hypokalemia because it was a broad complex bradycardic PEA. And then sort of had a discussion about toxins, which is usually lip service in cardiac arrests in hospitals, I suppose. But in this setting, the child had taken something about half an hour earlier that we didn't know what it was. Said briefly she was breathless and then turned blue like a Smurf, was what the information from the ICP was, and then she arrested in front of them almost immediately. And we just noticed some dark brown blood coming out of her cannula. So sort of all these things putting together, we thought, well, actually maybe this is a severe hemoglobinemia from some sodium nitrite, and which then meant that we can have a bit of a cohesive direction. We managed to call the kids' hospital ahead of time as we were driving there to ask for methylene blue for the antidote. And we got to the kids' hospital maybe 10 minutes later by road, where they continued resuscitation. They gave the antidote, but unfortunately the hemoglobin level was 90%. It was considered that it wouldn't be consistent with ongoing survival, and resuscitation was ceased. And you know, so we've got two high acuity kind of complicated cases with the same crew, almost back to back in the same night. And what I really wanted to draw from this was in particular when we debriefed each job after each job had occurred. So the first case, a 40-year-old guy, he was critically ill, but he had a good clinical outcome despite all the challenges involved. We had a really capable ICP who was team leading it at the outset, and because of my perspective and probably my own anxiety in this, I think my actions to sort of take team leadership where maybe that didn't need to happen, if I could have sort of encouraged him to do so further. I think he felt a bit unheard and overridden, and I apologize for that, and I tried to reflect on it as much as I can. But he came away from that job feeling really negative despite doing an excellent job, the patient having a good clinical outcome. And when we talked about this in the debrief, he said basically we'd arrived just as they'd extricated the patient. They'd just lost IV access, which they're really bummed about. And in his words, it was the worst possible time to have to provide a handover to another team. And that really kind of struck me of like, how our presence can impact when we arrive at these scenes. And in the contrast to that is the second case that we discussed, the 15-year-old with the severe hemoglobinemia. Like she was also critically ill. Sadly, had a very poor outcome despite getting excellent quality care as well. And even though the outcome was much worse, the debrief there was the team felt far more satisfied with how the job went, and they felt much more empowered during the job to work alongside us and with us with our sort of complementary skill set, rather than feeling what I might have described otherwise as bulldozed in the first case, which is my fault. And they really appreciated the efforts to integrate and the difference from the first case. And so that taught me a really valuable lesson quite early in my time at the service here about how important it is, those first few words. And again, we were just hearing from Nat about how the first few words when you introduce to someone who's having a really rough time can make a massive difference about how these jobs go and how people take away their feelings afterwards. So that was really what I wanted to sort of highlight out of those two cases there. But happy for questions or comments or whatever people are thinking. I might hand back to Angus for ease of logistics.
So yeah, this is just to set the scene. This was my first shift straight after induction. We're all looking happy and enthusiastic and ready to go. I had done my first ride-along helicopter shift with Sam Bendel, where we did 2 road jobs and just had a little scenic flight to Wollongong to end the evening, but didn't get off the helicopter at all until we got back. And then I came in for my first day shift. We got a back call probably around 10 or 11 a.m. and it was for an MVA on the Hume Highway. So we got off in the helicopter, and as we were on the way, some information was unfolding. Initially, it was going to be a 3-person MVA. And then we found out that our patient was going to be 6 months old. So basically, as my first day in retrieval was my biggest nightmare case, a small baby and a big MVA. So tried to mentally prepare myself in the helicopter and just kind of smiled and nod and pulled out my pediatric drug dosing card for security. And I'm just going to talk about a few of the different challenges faced and what I did or what I learned from those. So the first thing is obviously that it was a very confronting scene, nothing like I'd seen before. Lots of people everywhere. You could see the drivers of the cement truck that were involved in the crash, and just the people everywhere, and obviously the car. Someone had pulled our child out of, a passerby had just pulled out the child out of their baby seat, but the mother and older sibling were deceased, and that was, were already deceased when we got there. So I guess the main learning point from that is that I think the induction does prepare you quite well when they do all those things, throwing things at you, wetting you, having patients come around you, and just teaching you to get in that headspace of just do your primary assessment no matter what else is happening. Things will happen around you. There's lots of skilled people on scene, police, fire, lots of paramedics who can do all the other things. So it was just straight to the kid and straight to the assessment. The paramedic was very useful in, the kid was just sort of in an ambulance stretcher halfway between the helicopter and the car. And, in that background organisation and logistics of moving the kid to the helicopter, which I hadn't thought of because I just went straight into my primary survey. Another challenge that we had, or for me at least being my first job, was the team. So these are all the people that were involved in the resuscitation. We actually were really fortunate to have another medical team because they'd come for the other patients and then didn't have any other patient. Well, shouldn't say fortunate, but for me, it was good to have that extra support and the extra pair of hands. But we also had a ride along who we were not familiar with because they weren't on our aircraft initially, but sort of just jumped on when the job sounded exciting. And we weren't aware of that person's skill set or ability. So I think it's just, yes, be the doctor, do the medicine, but also be aware of who's on your team. We had some really, really helpful paramedics and people standing further back who were happy to get us things and help out in any way they could. So, focusing on what you need to do and using other people as you can, but also being able to step in when you think those people are acting inappropriately, and that can be overwhelming and intimidating in a new environment. But I guess it's an important responsibility for us. So that was a learning point for me. If I didn't know the person, I didn't know what they were comfortable with, and I felt like they were acting out of their comfort zone, or out of their skill set, let's say, I didn't feel like I could tell them to step away, but really that's what I should have done. So that was, good lesson about the team. The next thing was, you've got this pediatric dosing card, which is a really fantastic aid, but you can choose between a newborn or a 6-month-old, and our kid was somewhere in between that, and we didn't really know exactly how old she was. A few things that I've circled. So eye-gel size 1, which we don't carry, but it turns out the road crews do. So we were able to get helpful volunteer to bring that to us. As well as this, the ketamine induction dose, which I wanted to use, was 11.25 milligrams, which means giving 1.125 mils in our big syringe into an intraosseous, which was the only access we had. And my little tip for that was now that I always bring little syringes with me, because then you can draw it up and give the dose you want to give. Again, the road crew was super helpful in getting that organised for us, drawing it up, finding the size syringes, finding extra stoppers. But that's a good tip, to just always have something else with you in case you do need to give little doses of things. And then the last thing was, there were some decisions that we had to make. And as you can probably appreciate, it was a very busy, very chaotic scene. Lots of, it was highly emotive, and there were people everywhere. And there were a few things that I wasn't quite sure about. One is that we wanted to give hypertonic saline, but it clearly says in big red capital letters, not intraosseous. And the other thing was that I couldn't find any infusion doses on here. And so I was on my phone trying to get up the NETS calculator and work it all out, and it was all too much. And so my last lesson was just phone a friend when you need to. So we were able to call the DRC and get some of those big decisions and calculations offloaded, which was very helpful for us to just keep doing our hands-on things. That is all I have to say.
Any questions? Sarah?
Anything? No.
My sort of learning thing that I thought about was on my first ride-along shift. And I'd done a couple of jobs that was one, I don't know, some primary where the dude was fine and we'd send him with paramedics, and some other cardiac arrest where he was clearly dead. And I sort of thought, okay, I'm kind of getting into the hang of this. And my main sort of mantra at the beginning was just don't get in the way. Just don't get in the way of paramedics and everything else. And we went as a road primary to a siege. And at the time, I still didn't really know what siege meant. I was like, what does this mean? And it was some dude who'd been in his house saying, I'm going to blow myself up. I'm going to set this LPG thing on fire. And we got there and he'd blown himself up. And initially it was combative, agitated guy, loads of burns. And that was the sort of mist we were given. And we said, he's definitely getting a tube. Blah, blah, blah. And we get there and this guy's just sat on the stretcher in the middle of the road and he looked fine. He was super chill. And I thought, oh, this is this agitated mental health guy that said he's agitated, and he had to be held down by the cops and blah, blah, blah. And I was going from this definite tube to all of a sudden, like, actually looks kind of okay, but it's dark. And I'm having a look at him and he's clearly got some burns, but I just thought, it's a dark-skinned dude. And then I had some cop come up and he's like, how much burns has he got? How much burns has he got? And I was like, why do you care right now? Is this necessary? And so I thought, and then the para and the ride-along consultant, and I just get intimidated when there's consultants around in general, they're saying, what do you want to do? What do you want to do? And I was like, I don't know. I think we should just drive him to hospital. So we get him into the back, or maybe he was already, we get him into the back of their ambulance. And because the para was like, no, we're not going in ours if we can avoid it. And then I had a bit more of a look, and I was like, oh, he's got a decent amount of burns, actually. Most of this dark skin is actually just burns. And they were like, do you want an RSI? Do you want an RSI? Do you want an RSI? And I'd gone from like definitely RSIing this guy to now, actually, he looks kind of okay, and it's a flash burn, and I'm not 100% convinced he needs a tube. And I was like, no, we're not going to tube. We're just going to take him, because I'd worked out it was 20 minutes, half an hour to North Shore, whatever. And then I said, okay, mate, well, we're going to take you to hospital. And he just goes, I'm not going anywhere without this woman. To the paramedic. And I was like, nah, you're getting a tube. Okay. So then I sort of said, okay, guys, we're going to tube. And the paramedic was like, oh, make up your mind. And I was now at this point feeling like, oh, God, I'm really indecisive. And I've changed my mind. And everyone thinks I'm an idiot and I'm wasting time. And oh, this is not helpful. And then it's like, okay, we're going to do the RSI. And we've been through induction, and you've gone through the HEMS way of doing the RSI. And I was like, right, it's the stuff we need, and I know how to do this. We've just done this for the last week. I'm going to help. And so the para starts setting up the RSI and says, just get the key ones to help set up. And I was like, right, awesome. I know how to do this. And I was like, right, guys, we're going to get 2 cannulas. We're going to get a bag of fluid. We're going to get some nasal prongs. We're going to get some suction. But I remember them teaching that our suction is long enough to go from the band. So I take our suction out of the red bag, and I'm like, you plug this in over here. And I think I'm like coordinating like a maestro. And then the paramedic's like, Angus, where the fuck is our suction? And I was like, oh, I took it out the bag. And he's like, don't do that. Do doctor stuff. And that's the one thing that I keep now playing, which you'd think after however many years of medicine, I know that's my actual job. But do doctor stuff has kind of become my like go-to, like, oh, fuck, what should I should do doctor stuff. And I like to be helpful and get involved, but I was so in the way here. I was just like, oh no, I moved that and I moved that. And he's like, don't do that. Do doctor stuff. And of course, at the time you feel like this big because an awesome paramedic is telling you, you're an idiot. And I sort of stood back and thought, what doctor stuff? Like, he's fine. He just needs an RSI because he's going to be difficult behaviorally. And then he was like, right, okay, drugs and doses, what are you doing? I was like, oh yeah, shit. And then the consultant was like, I've drawn up some sedation. And I was like, oh yeah, that's good. And then they were like, we're going to put him on the ventilator. And I was like, oh yeah, that's doctor stuff. Okay. What about infusions? I was like, yeah, really good point. So all of this I can boil down to just do doctor stuff. And that was my main learning point, which is quite difficult for me to do when I like to get stuck in and help. But I'm now much better at saying, right, okay, what am I going to do after the tube, sedation-wise? Am I going to put them on the ventilator and all that sort of thing? And I haven't had tons of RSIs, but having had another one since then, it was so much better. We're going to RSI whilst you're setting up. I drew up sedation, got my drugs, got the vent set up, and actually thinking, Angus, what are you doing? Do doctor stuff. As a go back for me has really helped. So that's sort of been that was my main one. But I felt shit about it because it was not a good induction for me as a job, but actually it was an awesome learning point. So it really, really helped. Cool. Thank you very much. Ed's going to jump up and tell us a little something now.
Okay. So the case that I am going to talk about has some similar learning points to some of the other cases already discussed. Maybe a little bit of less exciting one, but it was just one that I did early on that gave me a couple of things to reflect on that I think would be useful. So this was on an orange day shift where we just come on. It was quite early and we got tasked from Orange to Mudgee by Hilo to pick up somebody who had a pharyngeal infection with some airway compromise to transfer them from Mudgee Hospital to Orange Hospital for ENT. So that was sort of the basics of it. We got a more complete handover from the state retrieval consultant. But one thing that you'll find in all of these missions is the SRC is just dealing with the information that they're given. And in this case, it's coming from a peripheral hospital, where I think the night team had seen this patient initially. They'd handed over to the morning team. The morning team had made the referral. So the information that we got through was a little sketchy, and it sounded like the description I was getting was that this patient seemed like they might have had a Ludwig's angina from the initial description. So we launched and started heading in that direction. One thing about working out of Orange is that sort of geography and meteorology will often affect your mission. And we were lucky that today was actually a good day for flying, so it could all be done by helicopter. It was quite clear we could go visual the whole way without any sort of major changes to the plan as a result of that, which is, we're fortunate. It's not always the case. On the way, I guess we'd already identified that one of the big decision points was going to be whether or not this patient was going to need to be intubated, and that it was unclear from the initial information whether that would be required. So we wait till we get on the scene to make a formal decision. When we got there, again, we were getting a handover from somebody who hadn't necessarily been involved with the patient for that long, and the information wasn't that much greater than what we already had. So I thought I'd start, I'd go and assess the patient, do a primary survey, then refer back to some of the imaging and the notes and pathology to get whatever other details I could. But the story that I was able to get was so that this was a 59-year-old gentleman. He'd been unwell for about 48 hours with a sore throat and some myalgias, some general kind of virally sounding symptoms. Apparently had not been febrile, but had been having increasing dysphagia, adynophagia, and he developed this hot potato voice and then had a choking episode overnight, which prompted him to present to hospital. He had some stridor initially when he'd arrived, but he didn't have sort of an overt respiratory distress and was able to lay flat in order to tolerate a CT scan. And the CT scan actually gave us what was probably the most useful information and had a much more concerning and impressive appearance than what had been initially described. So what it demonstrated is the actual pathology, which hadn't been handed over to me yet at that point. He had a left-sided peritonsillar abscess, which was about 2 centimeters in size, but then the inflammation from the infection had spread all the way down over his larynx to develop a quite pronounced epiglottitis, as well as inflammation of the supraglottic area, and with really only just a very narrow glottic opening of a couple of millimeters. So when I looked at the patient, there was quite a big discrepancy with how severe the CT scan looked to a patient that actually looked reasonably comfortable. So doing a top to toe on him, he was comfortable at rest. At rest, no audible stridor, although it had been documented he had some earlier in the night, and he was able to talk with clear dysphonia, a bit of reduced mouth opening, probably open about 3 centimeters, which is probably reduced for him. Had good neck mobility, but was also like very tender over the left side of his neck and even tender right over his anterior larynx, which was the first time I'd actually encountered a patient with such severe inflammation to cause pain just with anterior palpation. So in terms of treatment, he'd had ceftriaxone, metronidazole, benpen, 8 milligrams of Dex, and he'd had a 5 milligram adrenaline neb throughout the morning prior to our arrival. So based on this initial assessment, I came to the conclusion that I was really uncomfortable with putting this person with only a couple of millimeters of sort of, glottic opening into a helicopter where I'd have limited ability to perform airway interventions, and that we would need to do a fiber optic intubation at Mudgee in order to facilitate transport. So had a little chat with the CCP, who, from his perspective, having been there, disagreed with that point of view and said, no, I think it's a 30-minute flight at most, and the patient does, although the CT looks horrible, he doesn't look like he's about to lose his airway, and it would be such a difficult and dangerous fiber optic that to try and do that here without ENT immediately on site, we're more likely to do harm and cause problems for this person than if we were to just move. And I said, all right, that's an interesting perspective. We've got a disagreement here about it. I should escalate this and talk to the DRC about it. So I called Bankstown, and at Bankstown there were quite a number of people on base at the time, and I got through to the duty retrieval consultant, but there was also a number of different consultants around at the time, and they were able to get onto PACS and actually look at the CT images, and couldn't believe that the images that they were looking at was the same patient that I was describing, who actually looked quite comfortable. But after a discussion, they agreed very much with the paramedic as opposed to me. So that would be the most appropriate thing to do. But with a few things that, if he was to deteriorate, plan A is going to have to be to go straight to a surgical airway for this gentleman. So trying to do a supraglottic intubation is so likely to fail that we're just going to be wasting time and making things worse. That we would fly low in VFR the whole time, and the space between Mudgee and Orange is a lot of paddocks, and it would actually be somewhere where you could land on if you needed to do something in an urgent situation. That we would plan for, prep, and discuss our actions on in the event of requiring a surgical airway, and examine and mark landmarks and all of that sort of thing. Also to give a little bit more dex, and to give another adrenaline neb as well prior to transport. So doing a couple of other things to help temporize. And so we did, and the retrieval went well. The patient didn't deteriorate, and we brought them to Orange ED and was met by ENT. And later in that day, we returned to Orange Hospital on a different mission and went by ICU to check on the progress of the patient. And the patient had gone straight to theatre, and had an awake fibre optic intubation. And they said that the epiglottis had been so inflamed that just accidentally touching it with an instrument had caused it to drain some pus. So certainly an airway that would have been very challenging for me to have attempted myself as a emergency physician. That would be one of the most difficult airways that I would have ever encountered, one of the most difficult airway situations. So I guess the reason why I found this one a good one to reflect on was that it was a case of a disagreement between me and my understanding of the clinical situation, and then the retrieval considerations differing from that of the paramedic, and the importance of understanding, respecting, and listening to them with their experience. So that was one big part of it. I think another part of it as well is that when we get taught and understand all of these procedures, and I have done the awake fiber optic lessons, etc., and felt prepared for it. But another important part of that is understanding the indications, understanding all of the other retrieval considerations, and knowing when not to intervene. And in this case, it might be, the intervention that I didn't do that was most beneficial to the patient, as opposed to trying to. Then, as has been the case, a couple of people have already reflected that consulting the Brains Trust. So knowing that in most cases, there's time to have a conversation with the DRC about what you're doing and make sure that that's appropriate. Might not be the most high-end case, but it was just something that was quite thought-provoking for me. Yeah. Before I finish up, does anyone have any other questions or anything to clarify about that?
Straight in off the job. There he goes. Look at him, hero. All right, thanks, mate.
All good. Hey guys, so I've literally just come back from a job. That was good timing. I'm not quite sure what the other guys have gone through, but I've just got a few reflections from a big job I had at the start of my time here. So that's several months ago. My first few weeks were pretty quiet, and I could see all my colleagues doing these pretty big jobs and doing amazingly well. So I was always wondering whether I'd be able to step up and perform to the same level as those guys. And then after a few quiet weeks, I got woken up at 5:30 a.m. and had probably the biggest job of my whole medical career to date. Without going into too much detail about it, the patient was stabbed to the left chest and upper abdomen. And when we got to scene, was in a traumatic cardiac arrest, and it was a pretty high profile case. So we proceeded to go through our traumatic cardiac arrest algorithm. Didn't have any effect at that time, and remember looking up to the para, we made the decision to do a thoracotomy. And I was lucky to have an awesome paramedic with me. And this was a pretty big decision for me, coming from anaesthesia in South Island, New Zealand. I'd only ever read and heard about thoracotomies and never seen one before. So I think it just goes to show how good the training is here, that within a few weeks I'd gone from not being able to make the decision and not being able to do the procedure to be able to make a pretty confident decision, and from what I remember, felt quite calm during the actual procedure, even though it was the first time I'd done it. It was it was a bad outcome, unfortunately. And then one of the main kind of thoughts I wrestled with after having a bad outcome was, it happened to me on the day who got tasked to this job, and if someone else got tasked to this job, say it was one of the specialists, would the outcome have been different? And I kind of wrestled with that for a few days. And I think that's a pretty normal thought to have after a bad outcome, and I think that's okay to have those thoughts. But there was lots of support around with the organisation, and I think it's pretty special that we can work for an organisation where everyone's got your back. I remember coming back from the job, and Wallace, the therapy dog, was there waiting for us to have a play with at the end of the job. And there was always people offering support, offering a chat, and we're always there for you when you wanted to have a chat. Yes, that's the reflections I had. Cool.